Thanks so much, everyone. I'm excited for the discussion today. So for those who, I think I know most of you on the Zoom. For those who don't know me, I'm Brandon Marshall. I'm a professor in epidemiology at the Brown University School of Public Health, and also direct a research program called the People, Place, and Health Collective. I'm going to be talking today about overdose prevention centers, a hot topic in our state and across the nation. I'm going to share my slides. That's not working. So there we go. So what I plan to do today is, for those who aren't familiar with OPCs, I'll give a very brief kind of overview of what they are, what they aim to do, and then just highlight a little bit of prior research that I've done in other countries and that other colleagues have done, and spend most of the time today talking about the research that we plan to do here in Rhode Island once an overdose prevention center opens, in collaboration with our colleagues at New York University, who are evaluating the OPCs in Manhattan. Feel free to interrupt me throughout, and I'll try to leave lots of time for questions at the end as well. So that's what we're going to do today. Talk about OPCs and then focus on mostly point 3 there, looking at our plans for evaluation of these facilities, which was recently funded through an R01 from the National Institutes of Health. All right, so what are overdose prevention centers? For those who aren't familiar, these are spaces where people who use drugs can consume pre-obtained controlled substances under the supervision of trained staff. So some critical things here. Drugs are typically not provided on site. People bring pre-obtained substances to use. They obtain them elsewhere and use them under supervision. And that supervision might look like medical staff, like nurses, or it might be trained peers who respond in the event of an overdose. And we'll talk about what happens in those circumstances in a little bit later. One thing I really always like to highlight is that overdose prevention centers are a lot more than the immediate supervision and overdose reversal activities. Those are critical public health elements of these programs, but the vast majority of OPCs around the world provide a lot of other types of services: access to medical care, referrals to treatment and recovery programs, referrals to housing and other social supports, food, showers. There's an acupuncture program at OnPoint in New York City. So it's really meant to be a wraparound suite of services and a one-stop shop for people who are at risk for overdose. These are not new interventions by any means. The first opened in Switzerland in the 1980s, and there are now more than 200 operating in more than 14 countries. But they are a novel intervention in the United States. The first publicly authorized overdose prevention center opened in Manhattan in New York City in November 2021. And we are the first state in the nation to authorize OPCs through legislation, which was passed and signed into law in that same year. And we'll talk more about that a little bit later. The terminology in this space is very confusing. I'll use the term overdose prevention center today, or OPC. You might see the term supervised consumption facility or supervised injection facility. The law in Rhode Island actually uses the term harm reduction center. In Europe, drug consumption room is more common. But for the purposes of today, we'll just all use OPC. So I want to take you inside the first authorized overdose prevention center that opened in Vancouver in 2003. I was fortunate to serve on the scientific team that evaluated this facility during my PhD at the University of British Columbia, and want to walk you through the services and some of the research that we did before we talk about what's going on in New York City and Rhode Island. So this is a program called Insight. It's located in the downtown East Side neighborhood of Vancouver, Canada. It's what I like to call a kind of a Cadillac facility, very large fixed site operation with 12 consumption booths that you can see in the background of this photo. So once people register, they enter into the consumption room, which is what you're seeing here. They pick up sterile use supplies, which are located at the nursing station in the foreground of the photo. and then use at one of those 12 booths in the background. The mirrors allow the nurses to passively observe people as they use and intervene in the event of an overdose. They might provide oxygen or naloxone if overdose symptoms are occurring. They also provide safer injecting education, basic healthcare, wound care, and other healthcare services. What's not shown in the photo is the post-consumption room. And this is where I like to say a lot of the magic actually happens with OPCs. So once people use, they move into a different room that's to the left and not shown in the photo. And that's where you typically might see, psychologists, other healthcare workers, peer recovery support specialists who are engaging with people, building rapport with clients, and really working with them to learn, what do they need? Are they interested in accessing a treatment program, say buprenorphine? Are they looking for housing or case management? What other services might someone be interested in? And that's where a lot of that referral and connection to care really happens, is post consumption. So there are many overdose prevention centers everywhere in the world, as I mentioned. That is an example of a fixed site, large facility. It receives about 700 visits per day. I really like to highlight that there are different ways of thinking about these facilities, though, too, that are more adaptable, particularly for less urban environments where you have a more disseminated population of people at risk for overdose. So this is an example of a mobile facility. This is actually in my hometown of Kelowna, Canada, which is about the same size as Providence. And it's essentially a converted RV with 2 consumption booths that you see in the photo, and space also for some of those other healthcare and social service provision. And this is a facility that basically can drive around and provide care to people who might live in a more dispersed, non-urban environment. Overdose prevention centers can also be integrated into existing healthcare facilities. That's the example shown on the right. This is in a residential program for people living with HIV in Vancouver. It's a 2-booth facility. In Europe, you also see overdose prevention centers integrated into hospital settings, for example, or other primary care clinics. So I'll walk through a little bit of the research that's been done in other countries. These are highly studied interventions. We have decades of research that we in the US can benefit from to learn how OPCs work and their evidence supporting them. So there's way too much research for me to go through today, but I'll highlight just a few key studies for you before we talk about what we're doing here in Rhode Island. So we know that there has never been an overdose death in any overdose prevention center anywhere in the world, despite millions of use events. So that shows you, right, that overdose death is preventable with the right services available to be provided when someone experiences overdose symptoms. But one question that we wanted to answer was whether that those activities actually have an impact at a population level. So that was the question we sought to address and answer in this study that we published in The Lancet way back in 2011. So I'll walk you through the methods and the findings just really briefly. This was a retrospective study. We obtained information on where overdose deaths had been occurring in the city of Vancouver over a 5-year period that bridged when Insight opened in September 2003. And we extracted the location of injury, the location of overdose, estimated using a 6-digit postal code, which in Canada is in urban areas, a relatively small area, like a half of a city block. And we hypothesized that if there was going to be an effect, it would be concentrated within the immediate neighborhood of Insight, where we knew from utilization data, the vast majority of people who use the service resided. About 75% resided or spent most of their time within about 550 yards radius of the OPC. So that was our intervention area, so to speak. And then we looked at the pre and post overdose rates in the rest of the city of Vancouver as a quasi-control, and looked at the difference in overdose mortality in these 2 time periods before and after Insight opened. So these are the findings. This shows you the number of overdose deaths and the rate before and after the OPC opened within the 500-meter radius of the facility and in the rest of the city of Vancouver overall, and the rate difference and the percent reduction between those 2 periods in each geographic area. So you can see a couple of things here, a tremendously high burden of overdose death in the downtown East Side neighborhood. These are extraordinarily high overdose rates per 100,000. To give you some context, Woonsocket has the highest overdose mortality in Rhode Island, and its overdose rate as a city is about 68-70. So in this neighborhood, before Insight opened, we saw tremendously high overdose mortality rates, much lower in the city of Vancouver overall. And what we found was a 35% reduction in overdose mortality after Insight opened in this immediate area, compared to only a 9% reduction in the rest of the city of Vancouver. I really love looking at this information graphically as well. This figure shows you block level overdose mortality rates. The OPC is shown by the red star, and this is the area of interest, the downtown East Side neighborhood. And you can see reductions in overdose mortality in every single city block in this geographic region after Insight opened. This is another way to look at the data. This was added during the revise and resubmit. I really loved this reviewer suggestion to look at the data using a different geographic unit. So what we did here was re-aggregate the data to census tracts, which are larger, obviously, than city blocks. And this figure shows you the rate difference in overdose mortality before and after the facility opened. So a positive value means a reduction after Insight opened, ranked according to the x-axis of how far the census tract was from the location of Insight. And what you can see are reductions in overdose mortality really only in the 2 census tracts that are surrounding the facility, and pretty much noise in the rest of the city of Vancouver overall. So I want to talk now about whether OPCs help people enter treatment. This has been well studied in Vancouver and other places. I'll just show you one really nice paper that I like that was published by a colleague, Cora DeBeck, also in 2011. This is a prospective cohort study of a random sample of Overdose Prevention Center clients in Vancouver. Over 1,000 were enrolled in total, and at baseline, over 600 were not enrolled in any form of substance use disorder treatment. And after 24 months of prospective follow-up, over 40% had enrolled in and engaged in some kind of treatment, a rate that was much higher than had been observed in other cohort studies historically in Vancouver, and were going on at around the same time. The figure on the right is from a survival analysis. So the factors, anything to the right of the dashed line, are predictors of entry into treatment. And what you see is that regularly attending the supervised injection facility was significantly associated with an increased uptake of treatment. Also, independently, contact with counselors who work in that post-consumption room that I mentioned earlier. So this is providing evidence here that not only can OPCs provide a pathway into treatment, but in fact, the more frequently someone uses a facility, and in particular, the more contact they have with people who work in that post-consumption room, the more likely they are to enter into any kind of SUD treatment. I want to highlight as well, actually, that this study was published largely before buprenorphine was approved by Health Canada for treatment for opioid use disorder. So many of these early studies were done at a time when there were not as many available modalities for people with OUD in particular in this context. So this is one reason why it's worth doing these studies, I would argue, in the US now, because we have a very different context than in Vancouver in the early 2000s. Some of the criticism of this literature from certain actors points to the fact that much of this literature comes from one facility, and so how generalizable is it really? And this is one study that is my favorite from last year that comes from France. They have a really nice design. They have been enrolling people in a cohort study accessing 4 overdose prevention centers in 4 separate cities in France, and then enrolled people who were using syringe service programs as a comparison group in 4 other cities without OPCs, which you might argue provides a stronger comparison group than what was done in Vancouver. So this is a really nice article. I recommend having a look at it. It was published in International Journal of Epidemiology, I think, last year. So similar kind of design, prospective cohort study here. They looked at 3 outcomes in this study over 12 months, and they found that among people who used an OPC, self-reported overdoses went down by 67%. You can see overdose rates much lower here than we would observe in these kinds of cohorts in the US. So it's 3% at baseline compared to 1% after 12 months. Skin and soft tissue infections went down by 79%, and emergency department visits, primarily due to overdose, went down by 59% after 12 months. And this is all relative reductions compared to other people who were using syringe service programs. So this shows you, the added value potentially of OPCs on top of more traditional harm reduction services. Okay, I'll highlight one final set of research and then finish by talking about the plan in New York City and Rhode Island. So we talked about the individual benefits of OPCs. We and others have studied what impact they have on the neighborhoods in which they're located. This is a really important political, largely, question that comes up in a lot of controversies that emerge when there's sort of public discussion of these facilities. So I'll highlight just 2 studies for you. This is one that we plan to replicate actually in Rhode Island when an OPC opens. This was done in 2004, and basically the researchers did the following. They had students and research assistants systematically canvass the downtown East Side neighborhood 6 weeks before the facility opened and up to 12 weeks after it opened. So the opening of the inside is shown by the dashed line. And they systematically counted measures of public disorder in this neighborhood, the number of publicly discarded syringes they observed, the number of people injecting in public, and the amount of injection-related litter. And what they found was significant reductions in all 3 measures of neighborhood disorder after the facility opened, particularly as use of that facility started to increase, which is shown in the top left figure. And in Poisson regression models, they found that this effect remained even after accounting for other confounders like weather and police activity during the same time period. So that sort of shows you an acute impact on a neighborhood when an OPC opens. People are more likely to use indoors. That brings people off the street and reduces the amount of public drug use and injection-related litter. This is a more recent study that I'll finish with that Pete Davidson and Alex Kroll did and published in Drug and Alcohol Dependence a few years ago. Similar kind of design, but in this case using police incident reports in a city where there is an unauthorized overdose prevention center. We don't know where that OPC is for obvious reasons. They did not disclose that location because it's operating underground and illegally or without authorization. But they are able to conduct this research and have published several important studies, including this one. So what we're seeing here is standardized counts of police incident reports for various outcomes. In the neighborhood surrounding the unauthorized overdose prevention center, which is shown in green. The opening of it is shown by the dashed line. And then 2 comparison neighborhoods. One is the immediate adjacent neighborhood, which is shown in red. And the blue is a different control neighborhood, which is sociodemographically most similar to the intervention neighborhood. So the conclusion you make sort of depends on the control group that you feel is the control area that you feel is most appropriate here. You can certainly see an inflection in police incident reports after the facility opened in that neighborhood. Certainly here, there's no evidence that opening an OPC leads to increased police activity or crime in the neighborhood. And in fact, we have evidence that these kinds of outcomes go down. All right, so I want to finish now by talking about what's happening here in the US in the Northeast. As I mentioned, the first two publicly authorized overdose prevention centers opened in New York City in November 2021. There are two, one in East Harlem, one in Washington Heights, both operated by an organization known as OnPoint. This is the facility in East Harlem, which is in some ways modeled after Insight. It's a more medicalized model. You can see the injection booths in the back. They also have facility for inhalation of substances, basically a smoking room, which is right off to the right of this photo. This is on the first floor of the facility. On the second and third floors, there are medical services. They're really integrated in an amazing way with Montefiore healthcare system. They have primary care, in buprenorphine induction, access to other forms of treatment, mental health care, acupuncture, really a whole suite of services all integrated into this facility. The facility in Washington Heights is more of a peer-run model, which is more focused on overdose reversals, but still provides referrals to off-site medical care and SUD treatment. All right, so we were the first state so the facilities in New York City are authorized basically by the city government. They operate through an MOU with the city. They do not have state authorization. We are the first state to actually pass a law that publicly allows these facilities to open. As I mentioned, that was done in 2021. Part of that law requires the health department to promulgate regulations that would oversee and license these facilities. So that was done in late 2021, early 2022, I believe. And those regulations are public and available. I recommend reviewing them if you're interested. The state's opioid settlement advisory committee, which I also sit on, as does Dr. Burke and others, also approved funding these facilities as part of the fiscal year 2023 recommendation and 2024 recommendation last year. So that contract was recently awarded to Project Weber Renew and Kodak. They plan to open a facility in Providence in 2024 with that funding from the opioid settlement. I think the total is about 2.6 million over 2 years, but don't quote me on that. The final amount might have changed. I am happy to talk more about sort of what's going on currently, maybe at the end after we talk about the research, if that's okay. Unless there's any questions right now, maybe I'll stop before we get into the research study that we plan to do. Let me check the chat.
No questions in the chat or the Q&A yet, but certainly I don't know if anyone wants to go ahead and just ask.
Great. Okay, let me barrel through and we'll get back to this topic at the end of the talk. Okay, so I'm going to switch now and spend, I don't know, a little bit, 10 more minutes or so talking about the research study that we have planned. I am the principal investigator for the Rhode Island site. My colleague Magdalena Cerda is the co-PI in New York City. We have called this study SAFER. And we'll be evaluating OPCs that are already open and as they are open in both settings. So I want to start by talking a little bit more about a point I made earlier, which was, why do this study in the US when there's so much existing research from other countries on the individual and public health merits of OPCs? I think there's a few things here you can point to. The first is that we do have a unique context, particularly around our healthcare policy and the way in which these facilities are funded and supported. So in the vast majority of countries that have OPCs, they're funded by either national or provincial or state level health authorities. And so we don't know really how they operate in a system with a privatized healthcare system like we have. And that also impacts cost effectiveness of their services. So that's one thing that we really don't know in the US and we plan to study. In addition, we have a very different drug market. We have a huge fentanyl problem and a massive overdose crisis compared to most other countries that also might impact effectiveness and the way in which these programs can work most effectively. And policymakers continue to cite lack of US evidence. We love sort of US exceptionalism and cite lack of US evidence often as one reason not to move forward. That was one reason that Governor Newsom cited it as a reason not to support a bill that authorized overdose prevention centers in California recently. So the hope is that some US specific evidence might inform some of these policy debates here in the United States. So these are our study's aims. I'm going to walk through them really quickly. There are 4 over a 4-year period. The first is that we want to understand what impact using an OPC has on people's health. So that's an individual level aim, and we're going to do that through a prospective cohort study. The second is to understand what effect OPCs have on the surrounding communities in which they're located. We're going to do that through a number of different mechanisms, spatial epi methods, and a systematic social observation, which I'll talk about in a moment. The third aim is qualitative. My colleague, Dr. Alex Collins, and a colleague at Yale, Ryan McNeil, will be leading this aim, and they will be using qualitative and ethnographic methods to understand, what are the optimal operational context program models that can maximize accessibility of these services. They're also going to speak with staff to really understand in great detail the diversity of the program models that we might see in the 2 jurisdictions. And the fourth is a cost and cost effectiveness aim, where we want to understand their costs in a US context and the potential cost savings that accrue as a result of OPC use. And Serena Berens from Weill Cornell Medicine, who's a health economist, is going to be leading this aim. So as I mentioned, the first aim is a prospective cohort study. We're going to be recruiting 1,000 people in total, 500 in New York City, 500 in Rhode Island. We are modeling this design after the French study I mentioned earlier. So we're going to be recruiting people from the OPCs directly, and then a comparison group of people who use syringe service programs, but who do not use an OPC. So the entire population of people will be service engaged, and we want to try to isolate, therefore, the effect of using an OPC on top of already having access to harm reduction services. And we're going to follow people for 18 months with surveys every 6 months and monthly check-ins. So this is the timeline. We have baseline, monthly check-ins, and then a 6-month follow-up visits out to 18 months. The baseline survey does not take 30 to 60 minutes. I should have corrected that. We are starting to pilot the survey here in Rhode Island, and we rolled it out in New York City and are recruiting participants from OnPoint. We started that in early August. It's currently taking about an hour and a half, so it's long, but our staff are doing an amazing job at engaging with people and getting this information. And we'll continue to do that until recruitment is reached, at least 500 people in each jurisdiction. One thing I wanted to mention as well that really is a strength of our academic and research environment in both jurisdictions is that we're able to match self-reported data from the cohort study with administrative data from our state and city healthcare systems and addiction treatment systems. So we're going to, with consent, link OPC use data and self-reported data to emergency department discharge data, EMS runs for non-fatal overdoses, fatal overdoses, and buprenorphine prescriptions and other forms of SUD treatment. So hopefully that will help insulate the study from biases that arise as a result of loss to follow-up. So that's the idea, is to obtain rich, objective, sort of hard administrative information on people longitudinally. So sorry, I got ahead of myself. These are all of the administrative data sources that we are working with our state and city partners to link and extract. And I think I covered all of that. Yes, I did. Okay. So as I mentioned, aim 2 is spatial. We're going to look at the effect of OPCs on the surrounding neighborhoods. both acutely as new OPCs open using a method called systematic social observation, and then over a longer time period using spatial epi methods, really relying on a synthetic control group approach using administrative data. So I want to talk a little bit about the systematic social observation. This is all ready to go. We've piloted this in New York City, and it is ready to go. The staff have done an amazing job building this instrument. This is incredibly time intensive, so we will be looking for students and volunteers to help us do this as we move towards implementation in Rhode Island. So a little call there for people if you're interested in, or have students especially that would like or able to do this. Basically, a systematic social observation is a systematic way of comparing neighborhood level outcomes related to some intervention. So we're going to be looking at a number of outcomes, litter, police surveillance, public drug use, and the built environment, any changes that might occur when OPCs are opened, the implementation of structures that deter people from using drugs, vandalism, other harm reduction supplies, vending machines, really a complete and comprehensive understanding of how the neighborhoods are changing as OPCs are implemented. So this is what the design looks like. I've picked 2 addresses here at random. This Project Weber News office down Broad Street and RyCares downtown, but this is just for visualization purposes only. So we will center the analysis around a neighborhood in which the OPC is located and a control neighborhood. And then over 18 weeks that buffer the implementation of the OPC, you randomly assess the city blocks at random times throughout the day, some of those outcomes that I mentioned earlier. So the city blocks are shown in yellow, and then we need research assistants and students to, over those 18 weeks, systematically basically walk around those city blocks and measure the outcomes. We developed an online tool for them to do this that's available via phone or tablet. So it helps them collect all the information. They can take photos that are not identifying as well, that provides all of the data for analysis. This has been very challenging, I have to say. We've piloted this in the Bronx. The research assistants are very obvious. They are constantly approached by police, asked what they're doing, by people who are using drugs, by service providers. So there's been some safety concerns, very honestly, and other challenges, but the staff in New York City in particular have done an amazing job of troubleshooting, and I'm feeling confident that we're ready to do this when an OPC opens in Providence. And so this is the second method we're going to do with AIM2, which is a synthetic control approach. I'm not going to spend a lot of time on this. This all relies on administrative data. We're going to look at a number of outcomes, overdoses, real estate values, business activity, all using city or state records, and using a synthetic control method to try to isolate the effect of opening an OPC on these outcomes compared to other neighborhoods in the jurisdiction in which there is no OPC. So I'm also not going to talk about AIM3 a lot because I am not a qualitative researcher, and Alex and Ryan are really leading all of this work, but they've planned a very comprehensive set of activities, including field work, ethnographic field work, in-depth interviews with people who use an OPC and staff in both jurisdictions, and this will be done longitudinally. So that is all there for information. If you have more questions about this, I might refer you to Alex or Ryan who can answer them. And then they will do also targeted interviews with people recruited from the cohort. So it's a mixed methods approach here as well, where they'll identify specific topologies of people from the cohort, say people that have engaged with SUD treatment since using the OPC, and really understand, for example, what was that like? What was the pathway? What was the mechanisms through which OPC utilization helped you enter into treatment, for example? And there might be other emergent groups of people that we would like to invite to participate in these interviews to learn more about their experiences. So the final aim is the cost and cost effectiveness. This was actually something that the director of NIDA, Nora Volkov, asked us to add, so we did. And we'll be looking very closely at the both startup and ongoing costs of implementing OPCs in both jurisdictions using what are called microcosting techniques, with data sources including interviews with staff, site records, expenses, staff time, very detailed information to get, for the first time, highly, comprehensive information about what these cost, which is actually quite difficult to obtain in Canada because most OPCs operate under the health authority jurisdiction and they don't separate out a budget. Actually, it's sort of wrapped into the universal healthcare system budget. So this will be the first time I think we really have these detailed information globally, but in particular in a US context. And then we also want to look with benefits. So most modeling studies show that OPCs actually save taxpayer dollars because they generate benefits to the healthcare system primarily. They prevent unnecessary emergency department visits for overdose and hospitalizations. They reduce skin and soft tissue infections, which we saw, which are very expensive to treat, as I'm sure many of you know. So we want to study that and actually use objective data to get an estimate around that by using both the self-reported data and the administrative data to examine some of the cost benefits associated with OPC use. So that's pretty much all I have. We've got a really amazing study team from Brown and NYU and at COIS from other places, including in Canada, who have studied OPCs for many decades, and from state and city agency partners. We will be launching a website with support from the COBRE, which is phenomenal. So we'll be hearing more about this from Abdullah, who's leading this effort in September at the September Scientific Update. So stay tuned for more information about that. But we're very thankful for the COBRE for supporting this dissemination piece, which will be so helpful to get our results and information out to the public in real time. And we also have a community advisory board as well in both settings, who will meet twice annually to help guide the entire program. Oh, and finally, we are part of the Harm Reduction Research Network. So this was a set of studies that were funded by NIDA to support harm reduction research. I think there are 9 linked R01s. We were added sort of late as a ugly duckling, so to speak. But we're happy to be part of this research network. Really amazing researchers across the US doing groundbreaking studies in harm reduction. And there's a number of different services that we'll have access to, like dissemination, another site-wide community advisory board, engagement, email newsletters, blogs, articles. So we're excited to use that as another mechanism to disseminate our research. So that's all I have. I want to thank my appreciating my amazing team, many of whom are on this call and are really doing this work and helping us get off the ground in Rhode Island. Magda and many other colleagues that I am so fortunate to work with every day, and our students at Brown. And then, of course, funding. The original funding from the Insight evaluation was funded by the Canadian Institutes of Health Research. The COBRE has been critical, and funding from NIH as well. And we have some pilot funding from Open Society Foundations, which has been phenomenal too. And this is my email and our team's social media if you're interested in following us. We also moved recently to a new research site at 66 Pavilion in the south side of Providence, above the where Discovery House used to be. So come and visit too. We'd love to show you around and chat more about what we're doing. So that's all I have. I'm going to stop, and I'm happy to open it up for questions.
Again, I don't see any questions in the chat or anything, but feel free, anybody, to unmute yourself.
I see one from Justin.
Oh.
Hey, Justin.
Hi, Brandon. I've seen you do a little bit of this before, and it's hard not to get very, very excited about everything going on when you present the data. And it's just always very inspiring how much experience you have and expertise in this. So thank you for sharing. Maybe I'll try. I have 2 questions, and I apologize, but one of the things that I'm really curious about in how the different places are set up, if you have a sense of data on the services utilized, especially for the overdose prevention, things like this, the micro dosing naloxone or oxygen use for reversal of overdoses, or if there's other things. And then I'm sorry to take the time to a second question, but I'd be curious if there's preliminary data in New York City about the surrounding like needles, because I know from a publicity standpoint, it sounds like there is some reported concerns, and see if that's something that's just a perception, or if that is more of a problem in New York than others. So
Yeah,
microdosing needles, apologies. Thank you.
that's great, Justin. I'll start with that second piece. So OnPoint has been has been amazing at doing all this work and publicizing their own data. They're also excited with us to work and collaborate on an independent evaluation, but we are working with them. They also, provide overdose prevention services, but do a lot of street outreach and cleanup in the surrounding neighborhood as well. And they've reported on the amount of discarded syringes and paraphernalia they've taken off the street since opening. So they really see that as part of their mission. And we are, also going to study that independently. There have been some challenges analytically, I have to say. We've started to look at police incident reports, for example, 311 calls, and there's challenges. First, East Harlem in particular is like any other neighborhood in New York City. It has extraordinarily high rates of police surveillance and arrests, which makes it very hard to find an appropriate comparison group. So that's been very challenging for the New York team to figure out how to do that using different types of methods like synthetic control approaches. And then with 311 data, you have to be very careful because there are some groups in the area who are opposed to OPCs and are very aggressive about calling 311 to report, say, any syringe that they see. So as sort of like evidence that it's causing some kind of harm. So I really caution people who are sort of naively using administrative data. You want to think very cautiously about what's driving potential spikes or finding appropriate comparison groups. So we want to do this work really, really rigorously, and there are challenges. But yes, OnPoint is like reporting that data. And then in terms of overdose, what was your first question again, in terms of the way that overdoses are responded to, or the cost of that service provision?
More how they're doing. I know that OnPoint is using microdosing naloxone, which is something that I was unfamiliar with until I heard that they were doing it. I wonder if there's a comparison across all these sites. Is that something that everyone is doing? Is there a variety of how people are responding, or do you have a sense of what health services are being provided in the sense of an overdose?
Yeah, they've learned a ton about how to respond to overdoses, particularly in the era of such a complex drug supply. So I don't know all of the details. I do know they rely very much on oxygen and use naloxone more sparingly, and they're finding that effective. Then they have separate protocols for responding to stimulant-involved overdoses, which might involve cooling people or bringing them to a quiet environment. They actually have a little garden outside, so they use that to help people chill and calm down with the stimulant overdose symptoms. So that's why it's important to learn what people intend to use, and is the role that drug checking programs can play as well to help guide the overdose response when we know a little bit more about what people are using. I just saw in Los Angeles a really interesting project. They're actually starting to do like street outreach with oxygen on golf carts to respond. So I think we're starting to learn more. I'll put that in the chat. But OnPoint is definitely pioneering this kind of approach for sure. But other entities, agencies like this program in Los Angeles are picking up on it. Yeah. Michelle. Nice to see you. How are you?
Hey, Brandon, I'm well, thank you. What a wonderful presentation, and this is exciting. Thank you so much. I'm wondering, what have you seen at OnPoint, and even in regarding smoking, and in other locations regarding smoking? Because here, smoking so many more people smoke, primarily crack, than anything else. Obviously, that is not the substance that is the highest risk for having somebody overdose, but there are a lot of overdoses from smoking crack too with the fentanyl. So how are you seeing that playing a role in Providence?
Yeah, that's a great question, Michelle. So those services are available at OnPoint, as I mentioned. It's essentially like it almost looks like a smoking room at an airport, if you can imagine. So almost like a small room with a window that allows the staff to passively observe people. They do smoke communally, I should say. So it's not like individual booths, but in a communal room, like at an airport, basically. There is very little research on this. There was published last year sort of a review of the state of science on inhalation in these kinds of services. I'll put that in the chat. As you probably know, in Rhode Island, the regulations actually mandate the provision of inhalation services. And that was seen as actually a racial justice issue, because we know that people of color are more likely to use substances through inhalation. So the concern when the regulations were being developed that only allowing injection at these types of sites would not be racially equitable. So every site that opens in Rhode Island will, under state regulation, have to have these kinds of facilities. There are challenges with venting and how to actually have occupational health and safety in these settings. Those are largely addressed, I feel, in the regulations that the state developed, but it has actually been challenging in Canada because of such strict occupational health and safety and indoor smoking rules. So there's very strict rules on indoor smoking. And so that has actually made it challenging to implement inhalation services in the Canadian setting, but some do exist, or they might be, say, in more of an outdoor area attached to an indoor injection room.
I'm going to interject for just a second and say we just have a few more minutes. Dr. Rich and I both have a meeting at 12:30 on the Zoom site. So,
Okay.
and I know Ju and also Dr. Bernstein have been waiting patiently, and I'm sure Dr. Rich might want to say a few things too. So,
Thanks, Heather. I'll keep it quick. Yeah. Hi, Ju.
Hi. Thank you so much for giving this overview. I have 3 very hopefully quick questions. One is, was fatal overdose used as a primary outcome in your grant proposal? Just because I recently received reviews from NIH on my ODT study, and of course, the small number of fatal overdose, not enough power came up as a concern. So just wanted to ask that first. And then I have a question about partnerships, but yeah.
Yeah, okay. I'm pulling up the aims. I actually don't remember. I think we proposed a composite outcome, fatal and non-fatal overdoses.
Okay.
And then with an exploratory aim to look at fatalities separately.
Yeah. I think I'm definitely leaning towards there, or just using an implementation outcome. Thank you. My second question is about partnerships. So with the implementers being OnPoint and PWR and Kodak, what is or have you talked about the plan for involving them in the research component and the evaluation component, and even inviting them to be co-authors, just because this is also something that has come up frequently?
Yeah, this is extremely challenging, and we've had a lot of discussions with both entities because there are real concerns about this project becoming incredibly politicized. And I've had that happen myself in a Canadian context when, primarily like right-wing entities or groups start attacking the science and launch academic misconduct complaints and ask for all the data. There's a high risk of that happening in the United States, to say the least. So we want to make sure this project is beyond reproach. It has to be incredibly rigorous. And we have, some of our best staff working on this to make sure that happens, and are fortunate to have resources to do so in both institutions. But that has also shaped how we think about the collaboration with OnPoint and Project Weber Renew. We are partners in this. We need access to the OPC to recruit participants. So we have to have some involvement, but there needs to be some arm's length, and the evaluation, I feel, needs to be independent. So we've developed pretty comprehensive policies. They will be invited to co-author papers, for example, whenever we actually use their data, like OPC utilization data, for example, then it's their data, so they'll be invited to participate. And then we have an internal advisory board consisting of the leads of each AIM and OPC leadership, who will vet new proposals or new projects or papers, but there won't be like a veto rule. What we don't want is the OPC being able to also veto research. If we find negative findings, we have to publish those. We have to be independent. So we've had a lot of discussions to actually work through that relationship, but it's challenging. And I'm happy to share the policies we've developed if that's helpful for your other work. Yeah.
I love that. That's so thoughtful. Thank you. And I'll follow up separately about the harm reduction network stuff.
Sure.
We're running out of time.
Okay. Hi, Mike.
Hi. Thanks for a great talk. Jody, if you have a few minutes, I can just take my question offline, or if not, I'll ask it in the last couple of minutes here. All right, I'm getting the nod to go ahead. So,
Okay.
Brandon, I'm just curious, this I think is quick, but have anyone done like ABA studies of introducing a safe consumption site and then taking it away and seeing if overdoses increase when the safe consumption site goes away from a community? Or I was also kind of intrigued by the mobile van thing. I mean, this is all just curiosity here. Has anyone like randomized what area the van is going to stay in for a week and then look at what happens with overdoses in that amount of time?
No, so mobile facilities are incredibly understudied. That is one thing we would love to do. And if mobile interventions were to be implemented in, our jurisdictions, we want to be flexible enough to study them or partner with a jurisdiction who might implement one. Minnesota did authorize OPCs, I should say, recently through a budget process. I don't believe it's a state law, but there's 14 million in the Minnesota budget set aside for comprehensive harm reduction services, including OPCs. So mobile services desperately need more research. It's a huge gap in the literature. In terms of closure, this is something we are very concerned about after this article was published on the front page of the New York Times last week. So the US attorney in the Southern District of Manhattan came out with a very strong statement saying that he believes these are illegal and wants to shut them down. So that was shocking to the city and the state of New York, and is out of line with what you've seen most other federal officials state on this. But it showed us that we have to be ready to evaluate the effect of a closure. So we're developing some contingency plans right now to study that, because to answer your question, no, it has not been studied, the impact of closure on individual or community outcomes. But this article was alarming to us and suggests we need to get ready to do that in case that happens. So happy to chat more about the impact that this statement might be having, but all to say we are getting ready for that to happen.
Got it. Thank you.
Jody, over to you. Close us out.
Well, what a fantastic presentation and discussion. And I've got, I think I had 4 questions when I started, when the talk ended, and I probably have another dozen or so, but we are out of time. I guess the one question that, these are not designed to get people into treatment. They're not designed to get people to stop using drugs. And yet that's probably, if that does happen, and I'd be interested in your thoughts about whether it does happen. My sense is it probably does. If people get into treatment and stay into treatment after coming into an OPC, that would be very powerful data to convince people. Other than Nora's absolutely right to get check on the fundamental issues. So anyhow, I'll end with that.
Great point. Yeah. You know, we know from OnPoint, they say, the director, Sam, has said this many times, their entire staff are ready to be activated the moment someone expresses interest in accessing treatment. So they are ready to take advantage of any window of opportunity and really work with people and understand what is their experience with treatment previously. Everyone has had some experience previously, many negative. And how can they then work with that person to guide them maybe into a more appropriate treatment for them? So we hypothesize, given that that's happening, that will increase uptake of SUD treatment and long-term retention in treatment. But that's, again, Jody, the primary outcome for us because it is so important to look at. Yeah.
Great. Well, thank you, everybody. And till the next time.
Thanks, everybody.
Thank you so much.
Bye-bye.
Thank
Nice
you,
to see
everyone.
you.
Thank
Take care.
Heather, should I jump off?
Thanks, Brandon.
What's that?
Should I jump off? Or
Jump
we just-
off and then there's another link on your calendar.
All right. Thanks.
Thanks, Brandon.